Okay, if everybody is settled, I'm going to open the hearing. And my name is Deputy Louise Dublé. I'm the Chair of the Health and Social Security Scrutiny Panel. And I'm so pleased to welcome all of the members of the public who have attended today. I'm really, really delighted to see such a good turnout. I know there's some medical practitioners in the room as well, so thank you so much for coming. And welcome to the ministers and their team as well. Now, we usually hold these hearings in the rather formal scrutiny rooms within the State's Chamber building. So this is a different venue, slightly different format. It's a trial that we're doing to try and increase engagement, and so far it seems to have been successful. But please do fill in the feedback cards that you have on your seat there, because what we would like to do is reflect on how the hearing has gone, and if there's any other things that you think scrutiny could be doing to make our work more accessible, more interesting, more engaging to you, then please let us know, because we will trial other ways of doing that. So today we will be putting questions that have been sent in by members of the public, and also questions that we have compiled ourselves amongst the panel. So thank you to everybody who has sent in questions in advance. We had many question areas. We haven't been able to fit all of them in, but we have tried to put as many questions from the public as possible into this hearing. Minister, I'll ask you in a moment to introduce yourself. Just a couple of notes for the hearing. If you could ensure that you speak up. Can I just check that everybody can hear me where I am at the moment? Because this is slightly different technology to usual. And when you speak, you need to press the green button on the little box in front of you there. So has everyone located that and is happy with that? Okay, great. Yes.
Can only take four microphones at once, so somebody has to switch off in order to.
So hopefully we won't have four people speaking at one time. Thank you. And I'm going to do a bit more of an introduction than I usually do, just to set the scene and for members of the public today. But before I do that, I wanted to thank my officers, who some are sitting on the side of the room there. We've got some behind and around the room. And as I said at the beginning, this is a really different setting, and lots of additional arrangements have had to be made. And I can't underestimate how grateful the panel is to our officers for accommodating all of that and really delivering today for the public. So thank you to our officers. So the purpose of scrutiny is to scrutinise the government's actions and plans, and to help the public understand the reason behind policy decisions. We also assess the effectiveness of measures announced, and we explore any further improvements and discuss those with ministers. And our shared goal today is to establish whether the health needs of women and girls are being met with the urgency and priority they deserve. And I know that is something that is of great importance to the ministerial team as well. I'm going to ask everybody to do introductions now, and we'll start with my panel. If my Vice Chair could begin.
Deputy Jonathan Reniff, I'm the Vice Chair of the panel.
Philip Balash, I'm a member of the panel, and perhaps I could just say that I have to leave, unfortunately, just after 1 o'clock, and it will not be as a result of anything that you've said, Minister.
It's a relief.
Deputy Lucy Stevenson, a member of the panel.
And Minister, if you could introduce yourself and your team.
Deputy Tom Bennett, Health Minister.
Welcome.
Deputy Andy Howell, Deputy Minister Assistant.
Welcome.
Caroline Jenkins, I'm consultant anaesthetist, but I'm also the Chief of Service for the Women's and Children's Care Group.
Okay.
Sarah Evans, I'm the General Manager for Medicine, but also responsible for screening services.
Thank you.
Enda McVeigh, I'm a consultant gynaecologist.
Thank you.
Ruth Johnson, Director of Health Policy.
Thank you. And I know that you have some other officers. When they do need to join the table, perhaps at that point they could introduce themselves. Thank you. Okay, so I'm just going to set some global and historical context for women's health and the reason why we're here today. So throughout history, doctors have considered women's bodies atypical and men's bodies the norm, despite women accounting for half the global population. There have been some policy and social changes, particularly around the 1990s, that have started to turn the tide, but women remain underrepresented in research, and sometimes grossly so. And with many negative impacts. Historical bias, policies designed to shield unborn children from exposure to drugs and treatments, concerns about fluctuating hormone levels, confounding study results, mean that there are healthcare disparities. And biological sex can play a role in physiological, metabolic, hormonal, and even cellular differences that can influence how diseases present, and thus the effectiveness of any pharmaceutical interventions. Women, for some pharmaceuticals, have been found to experience adverse effect from medications at twice the rate of men. And this is one of the results of this underrepresentation in medical studies. We know that for some diseases, the symptoms present differently in women, for example, heart disease, and this is not always well known even amongst medical practitioners, so women are less likely to receive appropriate prevention and management of diseases. So that's the global and historical context, which of course is outside of our control, but that's one that our healthcare system is operating within. And I want to take a moment here to thank all of the healthcare professionals that we have in Jersey, because I know that there are many individuals who are working tirelessly on a daily basis, improving health outcomes and saving lives, and the panel are very, very grateful for all of the work that is done. In terms of the Jersey context, we recently had the publication last year of the Women's Health and Wellbeing Joint Strategic Needs Assessment Report. And this, again, I would like to thank the Public Health Department, because this brings all of the global and international context into Jersey and has local data in there and lots of information from hundreds of Jersey women who filled in the government survey. And we have used this report as a basis for our questioning to understand where we need to question the Minister. Some of the findings in that report, and if anybody wants a copy of it, there are some available, that women live longer than men, but they spend many more years in poor health than men. Only 27% of women in Jersey felt their mental health needs were being met. 1 in 4 women reported frequent feelings of loneliness. Women reported many barriers to healthcare, including cost, access to appointments, and lack of self-referral options. Half of adult women and 1/3 of girls are overweight or obese, and only 5% of teenage girls meet the recommended daily activity levels. Now, this report should be read, I believe, in context, in conjunction with the Violence Against Women and Girls reports. These two reports together give a really clear picture of what it's like to be a woman or a girl in Jersey, and I think both reports are real watershed moments for Jersey in understanding women's experiences that hopefully we can all learn from and improve our policies and legislation going forwards. In response to this report, government have implemented several measures. I believe they have announced the refurbishment and the reopening of Rain Ward, which I think is happening later this year, a gynecological services improvement plan, a social prescribing platform, and work on a termination law in response to our amendment. And we celebrate the work that the ministerial team are doing. However, there are still some concerns about the adequacy and the timeliness of these responses. One of the biggest concerns that the panel is hearing from women and from professionals is that the decision to scrap the standalone women's health strategy indicates a lack of long-term commitment. We are also hearing concerns around enduring cultural issues that women face when accessing healthcare, which will need a significant effort to overcome. We're about to start the questions. I wanted to make a remark about men's health because that came up at our quarterly hearing. So we are here today to talk about women's health, and our discussions will be centred around that. However, the panel are aware that there are some issues with men's health as well. So we are planning to ask some questions on men's health at our next quarterly public hearing, which will be on the 20th of May. And you're all, well, possibly not all of you, if we're in our usual rooms, but people are welcome to come and join that hearing as well and watch that hearing. Okay. Before we start the questions, Ministers, I would like to emphasise that we are very, very tight on time today, and we are always, I think, a bit tight on time, but the sheer volume of areas that we have to cover means that answers really need to be very concise, so new information, the pace at which you're delivering your answers, if you could just bear in mind the timings. And I do apologise in advance if I need to cut anybody off, because I need to make sure that we can fit in all areas that my panel are going to be asking. Okay. And just a note for the audience as well, could everybody check that their mobile phones are turned off, please, and that silence is maintained throughout the hearing. But do feel free to come and go quietly. Okay. Minister, given the global and historical context for women's health that I have just outlined, what comments can you make on how this impacts women locally in Jersey?
I think I'm conscious of time, but I think there's something that I should make clear to everybody here, and I thank everybody for turning up, because it was mentioned on the radio this morning that I was responsible for cancelling the women's health strategy. That isn't a fact. It was cancelled prior to me coming to office. My understanding is there wasn't a strategy in place. The intention had been to produce a strategy, but it was made plain to the previous health minister that there wasn't sufficient funding to deliver a strategy once it was compiled, and as such, I thought that was a sensible decision to take, that it wasn't worth producing a strategy and paying for it to leave it on the shelf. I inherited that situation and decided to maintain that position, but I wanted to make it clear that the decision not to proceed with it wasn't my doing, albeit that it was a sensible decision given the funding issues, which I'm sure we'll touch upon. I've spoken to such length, I'll just ask you to repeat the first question, if you would. Sorry.
Yes, so what comment can you make on how the global and historical context impacts women's health here in Jersey?
I know that there have been some comments about a misogynistic approach to healthcare, and I think that historically, the further back you go, the more that would probably have been the case. I'm very, very pleased to see that whilst there might still be some carryover elements of that by and large, there's an awful lot more women in senior places in health and elsewhere for that matter. For example, the new hospital facilities team, 3 of the 4 key players at the top of that are women. So I think we're getting towards the end of that, and we're very keen to see a complete end to that.
And what data do you have that demonstrates that the misogyny and...
From my point of view, it's anecdotal. I think it's an acceptance of the whole of history with men dominating everything, and I think that logically runs through virtually every element of society. But I'm very, very comfortable that there are some very competent women in powerful places in health, and I think that's all to the good.
Mm-hmm. And do you accept the findings of this report that is authored by Public Health?
Absolutely. I don't think there's anything that one could argue with.
So you understand there is still a problem with misogynistic attitudes in some settings?
There are some, in some settings, yep, and the sooner that can be got rid of, the better.
And how do you plan to tackle that?
Well, that's cultural, and there's an awful lot of things that you do in terms of culture, where I've taken the view that from a ministerial point of view, and encourage the team to do the same thing, is to be open and honest about everything, however awkward it may be. We're going to have some very awkward conversations about funding, and we've got to take that on those as well. And I think if you have an open culture politically at the top of an organisation, that eventually filters through. You indicate there's no place for anybody doing the sort of things that we're talking about here.
And do you take a gender-sensitive approach to your policy making?
I would certainly hope so, yes. I think all the people that I work with, I don't see any evidence that isn't the case.
So you understand that men and women have different health needs, and you take that into account when you're structuring your policies?
As I've explained to you, there are a lot of women in my life that are very, very close to me. Some of them are older, like me, and I see a lot of these problems firsthand. So
you won't find anybody keener than me to make sure those problems are resolved.
Could you give an example of how you've implemented this recently?
No, I can't handpick anything specific. Just to say that our general approach is one of openness, equality, and fairness of treatment, no toleration of misogyny or bullying, and that I like to think runs throughout all of the work that we do.
And Minister, thank you. You mentioned that the women's health policy was planned to be cancelled. Given the public feeling around this and the public feeling in favour of a women's health strategy, have you reconsidered, or would you reconsider that?
At this point in time, I can't, because I think this is quite well known. Our health budget was under an enormous amount of pressure. We spent more than was allocated to us last year, and I don't mind saying, because we said we'd be open and honest, it's likely that that's going to happen again this year. So we're under huge pressure. Where I'm comfortable is that we, in deciding not to progress with a strategy, which was unfunded, that we'd have some particular focus on what we could do within the means that we had available to us. And it's the Women's Political Advisory Group that's been leading on that under the careful guidance of Deputy Howell. And as far as I'm concerned, it's for women to identify the things that they think are most important. It's not for me to do that. I'd rather listen to women who want to put their list of priorities forward. I'll do everything that I can within the means available to make sure that we exercise all of that as swiftly as we can.
How much would it cost to produce a strategy?
To be honest with you, at the top of my head, I really don't know, but I will say this to everybody. I've been in politics 3 years, and when I first arrived, one policy after another ended up on my desk, and it ended up on the shelf, because when I went to people and said, how are we going to implement, what's the timing from implementing the strategy, the answer was there's no money.
Can any of the officers advise how much the strategy would cost to produce? Yes, sorry, I will try to. Yeah, thank you.
The microphones, I think, are only for the cameras, unfortunately.
Yes.
Oh, are
yes.
they? Oh, right. Okay. So, so with regard to the production of the strategy, it would depend entirely on what we set out to achieve at the outset of the strategy. But it broadly, we've now got the Jersey Strategic Needs Analysis, so we've got a lot of background information and evidence. But I think it would probably, if I talk about in terms of officer time rather than in terms of money, it would probably take one of my team of policy officers out of their work for about 3 to 4 months.
Okay.
Could I just make a point?
Thank you.
Because as head of policy, Ruth could explain a little bit about the pressure that she's under in terms of policy drafting, because A, there are no more resources to employ policy officers, and you cannot get them for love nor money. We're having a very, very difficult job in defining what priorities we work on, and we're under pressure from all sides. And Ruth is under extreme pressure.
Understood, thank you. We may come back to this area, but we're going to move on to the next question now.
So we know that historically women's health has been treated less seriously, both in research and in terms of some conditions and so on. Is there anything you can point to that you've been doing since you became minister to tackle any of those issues?
Well, as I made the point that initially the Women's Advisory Group said they wanted to focus and escape from them, not from me, wanted to focus on termination of pregnancy, IVF and contraception, and that's the work that's been going on, and that's the work that Ruth has been working on in terms of policy growth.
So in terms of the areas where women have been treated less seriously, there's evidence in here around menopause and things like this, pain management and so on. Are those issues being addressed culturally?
They are. I think we could probably bring someone to talk about the work. It's better that we talk, if you don't mind, the specialty advisors to tell us in detail the things that are going on. Perhaps
I think you'll need to speak up, Enders.
So which area would you like to?
So there are several issues there to do with pain management, for example, to do with menopause and so on, where people cited that their experiences weren't being treated seriously. And I wondered whether there's been any efforts
So menopause,
to address those cultural issues.
Yeah, so menopause is a good example. I set up and run the menopause service here for the last 3 years. There is no current waiting list for that clinic. Inside 4 weeks, a patient can be seen. But all women will go through menopause at one stage. So my colleagues in primary care are very able to look after that. What I then tend to see in our clinic is the more difficult end of it, where perhaps a woman's had an estrogen-sensitive cancer where it might be contraindicated for HRT, but there are other ways of doing it whereby there are other issues around that. So it's triaging and seeing appropriately so that we've got an efficient and effective service. For pelvic pain, again, in my 25 years at Oxford, we set up a national service for pelvic pain, and we have one some of the leading researchers and developers in that very complex disorder. And it is one of those Venn diagrams of many overlapping potential areas. Like all things in medicine, the key is always a diagnosis. Can I understand why there is that pelvic pain, and is there a learned ability to it as well too? Because as a woman gets pain, she can then feel more pain, and there is a supertentorial effect on it as well too. So you've really complex and needs a multidisciplinary team to manage this.
I get you're addressing the treatment side of it.
Yeah.
I was also interested in the cultural side and the experience that women had, and in particular the experience that they weren't treated seriously in some parts of the organisation.
Yeah.
And I wondered what you were doing at that sort of cultural level within the organisation.
So the culture can be leading from the front and showing this is how I do it, this is how I run it, this is the pathways we set up, an evidence-based pathway to manage those clinical scenarios through, and then ensure that you have regular teaching with your middle grades and other consultant colleagues on how actually we do it. But if there is a culture that is affected, it does take time to change it. It's not going to change overnight. But again, I think it is leading, it is asking the public, doing regular surveys, finding out what the issues are. Through our DATEX and SIs, we can actually have feedback to intermediary and senior colleagues. So there are processes in place that actually do this, and I firmly believe that we're moving in the right direction with this.
I wonder if I could just follow up slightly more specifically on some of the types of things that women would be experiencing over here, and acknowledging that we're a small jurisdiction, we can't have the best specialists in everything all of the time. Do you think we've got effective partnerships in place with other maybe specialist areas where we can link with them? Things like endometriosis, for example, comes to mind, and PCOS, those kind of things.
So endometriosis, I was fortunate that I set up the National Centre for Endometriosis in Oxford 25 years ago, and we've developed that, and we do significant research in that, which is a polygenic disorder, and many things can lead to it. So true, I think my consultant colleagues here in Jersey who have actually maybe come here from the UK, they can bring those links with them. So I can link into the MDT team in Oxford very easily with Southampton, with Guy's and Thomas's. So we do have that ability. Polycystic ovarian syndrome, 1 in 20 women have it, 1 in 3 women have polycystic ovaries. So again, a very common condition that is very well managed at primary care, and it's only when you get into specific conditions does it need to be managed at a secondary care level. So to answer your question, yes, I do believe we have those ties if we need them.
So the ties may be there on a consultant basis, but are there formal established pathways in Jersey so we know, and women who present with those conditions know they will be looked after, this is what will happen, they will be sent to Southampton if they need it? Or
once they get to our secondary level onto it, yes, those are very, very clear. It's that there can sometimes be some inertia going from primary care into secondary care, and it's important that we get actually those pathways pushed down and have regular meetings with and I sit on the primary care board to get that information down. At this stage, we should trigger forward. So for example, like ARU, there is now no necessity to go through primary care. You can direct refer into, so a very good example, into our secondary care level. For recurrent miscarriage, again, that can be a direct referral in, because there are certain conditions that women will know their diagnosis before they go to their primary care physician. They know that they can't get pregnant. They know that they've had 2 miscarriages. So they don't necessarily need to go through that gatekeeping, and we can speed up the process and accelerate that. And I think it's all positive measures that have happened over the last 2 to 3 years, certainly since I've been here.
Thank you. I want to pick up on the question about culture change, and you said that was being addressed through your work. Can I ask whether that's through implied kind of leadership and showing a good example, or is it made visible and explicit? Are there any policies or initiatives that have been initiated either at a consultant level or a ministerial level that actually say, look, there's problems that have been identified and we acknowledge them and let's tackle them, and you're visible.
Happy to make a couple of comments on that. One of the things that we identified soon after taking office was the fact that in our view things under the Charlie Parker regime had been over-centralised and to the detriment of specialised treatment within health, and bearing in mind that health is a third of our local budget and a third of our local employees, we felt that it was important to give health more autonomy. And there were 4 areas that we identified where we wanted to have somebody specifically in charge. There was HR, IT, procurement and finance. And in relation to HR, we've now got our own specific HR director, and that gives us a lot more focus on managing all staff matters, staff conduct, and that's going to put a lot more focus. That's only been the case since October, but I think great strides have been made, and that's been done in conjunction with the head of HR in the States generally, with their approval, and we're keeping those 2 people very much in contact with each other while we try and put real focus on HR and conduct issues within health. It's an important part of what we're doing.
That's helpful, thank you.
That does help to drive culture change. I'd also mention that this subject has been raised with the advisory board, and they're actually keeping a close eye on that as well.
Okay, thank you. So the HR professional that you mentioned is now embedded within your department. Could you commit to having a discussion with them and potentially the senior consultants around the cultural issues that have been raised in this report to see what initiatives could be put in place?
We do have regular meetings anyway, and cultural matters do. We can make sure that they're ultra focused, but there is a great deal of focus on culture change. I'm not telling any tales out of school here. There's been bullying issues and so on, and all of that stuff I think is reducing, and there's a particular focus on it. And I think you only get culture change by putting the right apparatus in place and having the right disciplines at the top table, and that's what we're trying to achieve.
So could you commit to reporting back to the panel on discussions that you've had with your HR team around
Happy
the
to have
specific
a separate section
issues
on HR if you want. We can bring the HR director along. That'd be fine.
Thank you. We look forward to hearing back about that.
I think we've covered a bit of this ground already, but I think the words that we use are important, and personally I'm not comfortable with the use of the word misogyny, contempt for women. I would like to think that is pretty rare in the health department. But what is concerning from the report is the impression that women are sometimes treated differently because they are women. And I'd like to know, perhaps from the Assistant Minister, whether she thinks that there is any prevalence of that kind of attitude in the department.
I think if there is, we would not tolerate it. This report is now slightly out of date, I think, and I think we have now a new chief officer in our health department, and we have the new HR department director, and I think these issues are very important. We think everybody, whoever they are, should be treated absolutely equally. And they should have kind and compassionate, safe care.
And how would you tackle it, Assistant Minister, if you found that was happening?
Well, I'm sure that they would be reported to the Chief Executive.
And is there anything explicit that encourages reporting of this kind of treatment?
I think we've now have a Speak Up Guardian, and I think generally all the staff know that they are not allowed to accept any behaviour that is not appropriate.
Okay, thank you. Would you also seek to investigate whether that is something that is encouraged, the reporting of the specific behaviours identified in this report, and get back to us?
It is, definitely.
It is, okay, thank you. Did you?
I'd also say that if anybody listening, and I'm not trying to get more emails than I get, but if there is any doubt from anybody, and they're scared to report this to anybody in the system, there's me, 3 assistant ministers, and email addresses are lots and lots of people find them already. But if you get instances of the sort that you're describing, people aren't getting the responses that they think they should be getting, they can always write directly to us, and we will ensure that gets taken right through the system. So that's a personal guarantee from people. They can email us. A lot of them do, and we're getting a very, very good response generally through the medical director or the IT department, depending on which area we need to look at. But things are dealt with pretty sharpish.
So can I also say that we have the patient advisory liaison service, which any patient is able to walk to.
Yes,
And
thank you.
we don't want anyone to feel they're dismissed either, because that's not good either.
Yeah, and thank you. We did meet with them yesterday, so thank you for arranging that.
Happy for people to go there first, rather than come straight to us, if that's possible, because there is a process, there is a system, and it works pretty well. So,
Can I ask, in terms of this report, we've been talking about specific things with it. Is there going to be a departmental response to the report, a strategic response addressing the issues raised in it?
So the Women's Health Political Oversight Group met yesterday, and we came up with a plan, but because it was yesterday afternoon, I'm very sorry we haven't got it all written up yet. But a lot of the issues regarding women's health actually aren't to do with the health service, they're to do with other things, wider things like financial security and housing and your life-work balance. So there are lots of things we can do, but we want to work with public health. Do you want me to go through what we want to do? But yes, do you want to?
If Bruce could actually articulate that, but he's
I can do it.
If you could keep it concise. Thank you.
Very concise. So the Women's Health Political Advisory Group met yesterday. They've identified 5 priority areas of action that they would like to address with regard to some of the key findings in this report. In a short period of time, we will be able to provide more detail around that. But also, really importantly, as Andy says, what this report is doing is it's talking about women's health and well-being in the round. Many of the factors that affect women's health and well-being are not within the jurisdiction of the Health Minister. They are about stress, life-work balance. Some of the answers and solutions to those are about things like childcare, about not just about the cost of childcare, but about wraparound care. They're about housing. They're about how women are enabled and supported to manage the particular burden that's common with those. And the Health Minister, as I'm sure you will are aware, has made a commitment, which he's spoken about on a number of occasions, to actually set up and lead a ministerial group looking at the determinants of health in the round, and that will include women's health. And this report and the findings of it will be fundamental to the work of that group. So there's a two-pronged approach to it.
But will there be a formal written account summarising how this is going to be responded to, including those overarching joined-up government pieces of work that will result, presumably?
Yes, we are. I mean, we want women on this island to thrive, and we're all here to do the same thing, all of us. And we will be writing to say what our actions will be as a result. We're very grateful for all the women who took the time to answer the survey, because it has given us actual evidence now on which we can base. So we produced the action plan in October, and we will be going forward again with more of what we can do.
The final question on this from me is you mentioned in December 2024 that there would be a statement of intent that would be published as a result of this. Is that something that's wrapped up in what you've already talked about, or is that something separate? And if so, when is that going to appear?
It's the same thing.
It's the same thing. Okay.
And how are you going to ensure kind of buy-in? I appreciate you've got a number of ministers on the Women's Political Oversight Group already, but how are you going to ensure that government-wide buy-in from the Chief Minister, from all of the Council of Ministers? Are you going to take it to Council of Ministers as an item?
We're setting up a group with all of the concerned ministers. As I say, I think, as we were saying, I think health and service issues will account for 20% of what leads to women's in health. So we're going to be looking at all the other ministers that are responsible for all the other areas, and we'll be starting to work together collectively to try and address all these problems as a concerted piece of work. And I think unless we actually do that, unless we integrate those processes, we're not going to get to the bottom of it.
But before appreciating that that's going to take some time to come together as well, will the women's health response be going to Council of Ministers at the moment immediately?
We only met yesterday afternoon, so we haven't done it overnight, I'm afraid. But we will work as at pace as quickly as we can.
What's most important is that it goes to the executive leadership team and to everybody that's involved in actually delivering the stuff, so we can go and do the work.
But appreciating that there's executive leadership teams in your department, but there are across government who all need to work together on this.
The cross-ministerial group to ensure we with all the relevant parties to make sure we join the dots.
Yeah, but that's a general health one, of which you've said women's health will be a part of it.
Yeah.
What I'm trying to say is women's health, at this moment in time, how are you going to make sure you get that buy-in from everybody now in the immediate response to it as well?
I think we've got that buy-in already. This is a continuation, this is work in progress. This is not new to the Council of Ministers. They're fully aware that there's a women's health group that we've got an assistant minister working on women's health, and we will periodically have discussions with other ministers all the time. As I say, it's work in progress. It's not something new. The next round of work that comes in will be straight into the system and put into practice.
I commit to carrying on to working with all of the team.
And the statement of intent will go to the Council of Ministers, will it?
Yes.
Yes. Okay, thank you.
I think it must be fairly obvious, but I was going to ask who within government, who within the department is going to carry the specific responsibility for ensuring that these recommendations are looked at and seen through, and that presumably will be Assistant Minister Hull.
Okay, so I think we've touched a bit on this in terms of your statement of intent and the areas. I'm not sure if you actually outlined the 5 areas that you were going to cover in that. Could you just clarify what the 5 areas are, and are they the 5 areas taken from the report?
The first one was we're going to work on healthier lifestyle and ageing well through targeted joined-up evidence-based programmes.
Yeah.
We are hoping to improve work-life balance through increasing childcare offering, but that will be dependent on working with the Minister for Education. We're going to improve screening uptake. We're going to have opt-out screening for breast cancer, opt-out screening for cervical cancer, and we wish that the HPV vaccine uptakes greater. And then we're looking at how we can improve gynecological and reproductive health, how we can get rid of the stigma attached to menopause, get people talking about women's issues so they're not a taboo subject anymore. I think we've got lots of work going on, and we're going to then also look at how the contraception services are working in that.
Okay, thank you. So in this report, some of the determinants of health that were mentioned around gender-based violence and safety concerns, how will you work with other ministers to ensure that this is tackled?
We've also committed to implementing the health recommendations made by the Violence Against Women and Girls Task Force. So every GP now undergoes something called IRIS training, so they're aware of what to look for, what questions to ask.
Yeah, thank you. And could you update us as to the timings of those recommendations? When are they due to be completed from the VORG report?
I think the IRIS training is already underway.
Do any of the officers have information about the timings of those recommendations?
I don't have the information off the top of my head, but I can certainly provide it.
Yes, please do provide that to the panel after the hearing. Thank you. I would also like to ask about another area that was identified in this report, economic inequality and financial stress, particularly on single parents. And there is a notable gender pay gap in Jersey, which can also have an impact on women's health. What is government doing to tackle this?
I think government have identified that this is a problem, and I think for single often it's mums who are left doing looking after children, and I think it's really hard for some of them because they have to juggle 2 or 3 jobs sometimes and childcare and to make ends meet, and then they don't have any what every woman needs to have is a bit of 5 minutes for themselves every day. But I know that's really hard, but that's what we should everybody. So we're hopefully working with the children's minister, and he's starting a pilot for childcare for 2 to 3 year olds, I believe.
It's great that you're aware of the difficulties that single parents face. What specific policy interventions are you planning to tackle those issues for single parents?
I think these are early days. We haven't even had our sort of inaugural meeting yet, so we're actually putting this group of people together, and that's ongoing. So, yeah, there isn't a rollout ready to go. That's work in progress.
But we have started free school meals for anybody, for every child who needs them in, I think, all schools. I stand correction.
There's work going on in each department, but it's not as well threaded together as it could be, and as we intend to make it by virtue of initiating this group.
Okay, so are free school meals currently available to every single parent family?
Not to everybody. I think
I think that's
primary
every
schools,
school.
is it not? Yeah,
And
it is.
I think it is.
Could you check on that and report back to us, please? And if they aren't currently available, is that something that you would support?
My understanding it is that they are available.
To single parent families,
Yes.
all single
Well,
parent.
every child.
It's not free for every child.
It's not free for every child, but if your circumstances are such that you require it, then it's free.
So is part of that criteria, are single parent families able to access the free school meals?
I think it is a matter for education minister. We can't come along with that commitments on the matter of education. That's beyond our remit, I'm afraid.
Would you support that if it came to the Council of Ministers?
It depends. We have to look at the detail.
Okay. Another group that face more barriers than some are women with disabilities. What specific policy interventions do you have to address this?
That's not something that I'm familiar with in terms of that as a specific number.
I think everyone with a disability is treated as equally and their disability taken into consideration.
So you may well be aware of the work that's being done by the Social Security Minister and through her team, which is around providing more support to people who have disabilities, whether they be men or women who have disabilities, particularly through the work around social prescribing and about creating social connections, because one of the things that we know about people with disability, and this applies to both women and men, is that not only do you have the challenges associated with your disabilities, but those often lead to a great deal of social isolation, which compounds mental health, which compounds loneliness, which creates the vicious circle. So this is something that the Social Security Minister with her team are directly tackling at the moment through their social prescribing initiatives.
So there is evidence that shows that women are disproportionately affected by disabilities and also by long-term chronic health conditions such as autoimmune conditions. Is this something from a policy point of view, Minister, that you are aware of?
Not specifically, to be perfectly honest with you.
Now that it's been brought to your attention, would you commit to reflecting on that and examining what policy interventions you could make to address this?
I'm surprised that the professionals that live in those areas aren't aware of them and haven't dealt with them already, but I'm certainly happy to have that discussion to see the extent to which there is the case.
Thank you, and if you could report back to us. Thank you, we'd appreciate that.
So the report also highlights gaps in gynecological and reproductive care. What actions are being taken to address some of those gaps? For example, delays in diagnosis for conditions like endometriosis or polycystic ovary syndrome. I think we touched on that before, and address the lack of specialist support for these conditions. You will correct me if I'm wrong, I'm sure, Professor, that am I correct in thinking there's no, for example, there isn't somebody who specialises in endometriosis as a go-to individual, or But we lead the service is what I'm trying to say. I think you have a lot on your plate as it is already, don't you?
No, so endometriosis, approximately 25% of women will have endometriosis to some degree. If you look really hard for it, you can find it probably in over 50%. Endometriosis is a very specific condition in that the amount of disease you have doesn't always correlate with the symptoms that you experience. You can see a woman with quite severe endometriosis with no symptoms, whereas women might have a few spots of endometriosis and have a lot of symptoms. So you've got to work through that pathway. The average age delay in diagnosis in women over the age of 21 is 5 years. This is on a UK basis. The average delay in diagnosis for women under 21 is 7 years, because the only way that you can diagnose it is through a laparoscopy. Everything else is subjective. The only objective way is through surgery. So you have to, at a secondary and tertiary level, make a decision between a risk-benefit analysis. How am I going to cause risk to this patient by doing surgery versus how likely am I to change the outcome? So if the woman comes with pelvic pain or menstrual pain, then that's very well managed in primary care with a presumptive diagnosis of endometriosis and using the oral contraceptive pill, as many of my primary care colleagues do. It's only when it comes to a reproductive failure or to persistent failure in the primary care then that would come to my desk. And my colleagues, general gynecologists, can look after it, but if it gets more difficult and there is what's called type 4, stage 4 endometriosis, then I would see it, and my colleagues in the hospital would refer to me, and then I have the network to tie into.
So to summarise, there isn't in the case of endometriosis, there isn't an endometriosis clinic as such. It's dealt with at primary care, but if it gets to affecting reproductive health, it would come to you.
Or significant bowel or bladder involvement, then I would get involved as well at that stage. But this is similar to any DGH in the UK. There's no Pacific endometriosis clinics. There are about 20 Pacific endometriosis centres set up in the UK, and those are usually at tertiary levels. So in general, my colleagues in the UK will manage this at a secondary level with many other conditions that are gynecological, but only if the diagnosis is stage 3 or 4, where it is involving other organs, then is it referred on. And it's quite similar for polycystic ovaries. Again, 1 in 3 women have polycystic ovaries, 1 in 20 have polycystic ovarian syndrome. It is very well managed in primary care through appropriate pathways, and then referral on when there is treatment failure at that level.
So the report highlights that there are gaps in those areas. Do you accept that? Do you agree that there are some gaps there that could be filled, or do you think it's all working in the best interest of patients?
I think that one of the joys of coming to Jersey 4 years ago is that this is a small community, and it's a small medical community. And I know that most of my gynecological colleagues know what my expertise has been, and hopefully a lot of the primary care team, and that is direct access. So if there's failure to access that service, then there may be other perverse incentives or otherwise that are involved in that process.
And the relationship with GPs, primary care, do you think that's as good as it can be to allow those pathways to flow through to you ultimately?
Yeah, this is always, you never achieve your goal, and that's across health in general. If you think you've achieved it, then you're misinformed. You're always striving. There can be better information, there can be better relationships. We have more evidence coming out all the time on different disease conditions, so you need to constantly update that and keep that information flow and those relationships alive. As new practitioners come on board who start working in practices until they need to understand. So frequent regular meetings with them, and having the primary care board where we can disseminate information down is but that's all we can do, is disseminate the information.
Thank you. And in terms of information, one of the recommendations in the public health report was improving health literacy and education around gynecological health. Is this something that will be carried out?
Yes. Yes, it will.
Okay. Is it underway already, or could you advise the timescale?
It's something that we are mindful that we need to make sure that every woman is aware of the various, I think in NHS Scotland, they have NHS Inform. So I think it is something I'm aware that it's a gap.
Thank you.
Yeah. We're going to jump over.
It's the same topic. So.
Okay. Just a question then on Rayner Ward. can you provide an update on the refurbishment plans for Rayner Ward?
So we went for a visit last week, and it's underway. It's closed at the moment, but they're refurbishing it, so it'll be.
So when would it be planned to be brought on stream?
I think hopefully October.
Can I just clarify? So is Rayner Ward is the ward where the gynaecological services are delivered, is that correct? Yeah. Sorry, carry on.
So can you provide any information on the status or content of the planned gynaecological improvement plan being developed?
Yes, so the original plan was to incorporate a minor ops theatre in that area, but it's a very, very old part of the hospital, so we couldn't get the ventilation for that. So we're redoing the outpatients area. The minor ops suite will remain where it is, and the Rayner end of what is the surgical floor.
Would you mind speaking up a little bit? I've just had some indications that...
I've never been told I'm too quiet.
Big room.
Yes, so it's hard to, but we had basically we have three areas which we would call Rayner Ward. We have a minor ops suite where we do colposcopies, outpatient hysteroscopies. We were planning on putting a minor ops suite into the end of Rayner, so that we could have one whole area, but we cannot do that because of the age of the building. It's in the old granite block, and we cannot get the ventilation that we need when we're dealing with colposcopy patients. And so that suite will remain where it is, which is in the day surgery unit. And then the outpatient area is being totally refurbished. So we'll have 4 clinic rooms available for general outpatients, gynae outpatients, our early pregnancy assessment unit, our gynae oncology, all of our clinics will happen there. And then the Rayner, what used to be Rayner Ward, which is the far end of the surgical floor, will become a women's area. It won't just be gynecology, it's going to be breast, but that will be basically a women's ward.
I'm happy with that. Yeah. Moving on to questions of pain management. There have been persistent reports that women's pain is treated differently to men, assessed at a different level, given different scoring and so on. Is this a problem in Jersey, and what are you doing to tackle it?
Yeah, so pelvic pain, if it's pelvic pain as opposed to any other type of
we're
pain.
talking general pain. So just to clarify, so we're referring to a study that was led by King's College. So it's not necessarily Jersey data, but found that there was consistent differences in how male and female patients were treated for pain. Their pain scores were less likely to be acknowledged, less likely to be noted down, and they were less likely to be prescribed effective pain medication. So what we'd like to understand is that's the kind of national context. What's the situation in Jersey?
I mean, I'm an anaesthetist, but I'm not a chronic pain specialist. But we have good access to the pain clinic. That's for chronic pain. We've got 2 consultants and an associate specialist, all of who commonly see women and men with chronic pain issues. I would be very interested to see Jersey data on that, because I really don't believe there is a discrepancy.
So we do have some Jersey information. It was highlighted as a concern in the report. So what's your response to that, Minister?
The response to that is that we carry on this dialogue with the pain specialist. As I say, we're going deep into a particular specialist area, but I can't answer those questions. So very happy to have those ongoing discussion with the head of pain management.
I think the pain. You're talking about pain. There is so many different areas. If we're talking about chronic pelvic pain, which is a lot of the patients that we will see in the gynecology clinic, that is one area. But chronic pain that's seen up at the pain specialist is a different. I mean, it's such a huge. It's 50% of our population. We'll have those sort of issues.
I wonder if you can clarify the criteria used to determine when pain relief, for example, local anaesthesia and so on, is offered to patients during procedures, and ensure that there's consistency so that men and women are treated equally in those situations.
I know what pain relief we use for women who are having gynecological procedures. I mean, I'm an anaesthetist, so I spend a lot of time anaesthetising patients, both men and women. We give women a patient leaflet prior to them having an awake procedure that recommends that they take analgesics prior to coming in, simple analgesics, before and after. And we use local anaesthetic block techniques when they're having hysteroscopies, and they can also use endonox like gas and air for the procedures. We have that available. Very few people take that up, but some patients do. And if they require, we have much higher number of patients who have a general anaesthetic for more simple procedures such as marina coil insertion, marina device insertion, than we would have in the UK. But I don't know about the differences between men and women, other than I treat all my patients under anaesthetic in the same way.
The Government of Jersey website, in terms of contraceptive implants, coils and so on, lists paracetamol and ibuprofen as the pain management, but the private sector offers local anaesthetic or gas and air. Why
That's
is
the
that
same in the
difference?
hospital, exactly the same in the hospital. I don't know about Le Bar Centre, I'm afraid, as to whether they do or not, but definitely we offer local anaesthetic. In fact, we do local anaesthetic if patients require it. A lot of patients don't. Simple analgesics is enough, but those, if they particularly haven't had a baby before, will struggle with pain. And as I said, that's why we often patients are referred to have a general anaesthetic or some sedation, but that has to be within the hospital.
How do women know that that's an option to have that effective pain relief if it's not visible on the website?
So every patient is given a leaflet when they go to outpatients.
Okay, thank you. Minister, could you undertake to update the website so that the full range of pain relief options is made clear to women on the website? Thank you. Okay, do you want to go on to...
Yeah, just a couple of questions about the breast screening service. And I noted you said earlier about moving to an opt-out system as well. I wonder if I could start by asking that the panel's been made aware that there's a limited number of mammogram appointments available at the hospital, and that women are being signposted to the Enid Kenno, which we've heard anecdotally maybe putting some people off, for example, if they can't get there as easily in a working day, for example. Is that something you're aware of?
Can I pass you over to Sarah Evans, who's in...
Can I just make a note about timings? We are already very behind on the timings, so we'll need to speed up a bit to get through the questions, but please go ahead.
Thank you. So Enid Kenno has got a new purpose-built breast screening unit there, and the idea of that is that it enhances the patient's journey. So if you go for breast screening mammography at the general hospital, the patient journey is not very nice. The area where it isn't the best. It's next to oncology, and that leads to not a great patient experience for a lot of people. So the new breast screening service at Enid Kenno has been purpose-built, and we've recently done a patient feedback survey, which we do to audit all our new services. And of that, 89% of people said it was very good, and the other 11% said it was good. But one of the really interesting parts that we found is people are perceiving that they're having less pain when they're having a mammogram. So a mammogram isn't painful, but it's not comfortable to have. And we think that's because the environment is nicer for them, because there's absolutely no change in the tests that they're being offered. If people can't get to Enid Kenno, then we can see them at the general hospital, but because of the environment, we would prefer to see them up at Enid Kenno. That also then allows more time for our patients who are symptomatic to be seen at the general hospital, and frees up more slots for the cancer patient pathway.
Great, and that's really positive to hear some
Really
good feedback as well, and particularly around pain. Very fitting given the last questions. Could I just ask, before we do move on, about the move to the opt-out system? Has that been coming already? Is that in place? When's that going to happen, please?
So that will happen this year, and that's been made possible due to the new site at Enid Kenno. Before that, we only had one mammography machine, so we physically didn't have enough clinical space or time to see everybody, but we knew that we were missing some women. We had done an audit and we knew that people weren't registering as they should do. So that was one of our targets last year with the women's health and with the cancer strategy, to make it opt out. Now the new site has been operational since November. We're working to make it opt out, and it will be fully opt out by the end of this year.
That's great, thank you. And in your answer there, you managed to cover pretty much all of the questions we had planned. So that's thank you very much. We're going to move on now to contraception. And Minister, in a previous quarterly hearing, we discussed how young people are facing some challenges with accessing information around different contraception options available. Has that evolved since the quarterly hearing in autumn of last year? Has the support there improved at all?
That is something that we discussed yesterday afternoon at our meeting, and it is something that we will be working on. But it's quite complicated because we need to work with the clinicians and the policy, everybody, it's a joined up piece of work.
Quite incoherent tonight. It's probably useful for Ruth to give you a very quick rundown on.
I'm just noting the time. So there hasn't been any movement yet, but it is part of your plans. Yeah, thank you. So we also discussed about the very high demand for access to free contraceptive medication from community pharmacies. And I'm going to read a quote from this report from somebody who filled out the survey. The government should set up a similar sexual health clinic that is free. Even having to pay for my contraception pill now feels unfair when men do not have to pay for this. There are free condoms available everywhere. Why is the price burden put on women? Can you respond?
I'm going to ask Ruth. There's no chapter and verse on this, and get a much more clear answer. If you could be.
We will go through it in a second. Could I just have your reaction to that quote, Minister, or Assistant Minister? Oh, the Minister, yes. Yeah. Whoever wants to respond to that.
So, I mean, it is something that we addressed. We are in the process of addressing.
Okay, so it's part of your plans to make the contraceptive pill.
It's not it's one of the 5 things. We have to look very carefully. At the moment, contraception is free for everyone up until 23.
It's helpful, I think, for Ruth.
Okay.
No, it's okay, you can finish.
So it's up until at the Le Bar Centre up until 23. If you go to your GP, GP is now free up until 18 or up until 21 if you're a student. So then that's completely free. So we know it's something we're working on.
Yeah, so the charge, I think, would be if you're having the 2 GP appointments per year with perhaps free prescriptions, it ends up being around £100 a year, roughly, doesn't it?
Yes,
so that's the cost, I think, that women are facing.
Yes, in fact, I think,
Yeah. Sorry, let's just let...
I was just going to say that previously this piece of work had been delayed, I think, because of resource challenges. Can you just confirm you've got the resources to go ahead with it this time?
Same resources, it's moving up the priority. As I say, we are very, very tight on resources.
So it's
I'm very, very keen for Ruth to explain how the situation's evolved and how confused it is at the moment.
So it's moved back up the priority list, is the...
It was on the previous list of 3, it's now sort of on the last one.
Thank you.
It would be helpful for everyone to understand how we carry out the current system.
Can you do it in 30 seconds?
Certainly. It is the situation is a mess. We have no single coherent offering for women. We are acutely aware of that. Once we have got the termination of pregnancy law work that we're currently doing done, we will turn our attention to how we develop a single, simple, coherent contraception offering for all islanders. That does not necessarily mean that it will be free for all islanders, but we will certainly focus on good access to affordable contraception for the majority of women.
Thank you. I think it was probably less than 30 seconds. In terms of access to medication, the panel has received submissions which raise concerns around the emergency hormonal contraception, which is called the morning after pill, available to islanders over the counter. And we've heard that the statistically more effective option is considerably more expensive in Jersey than the alternative option, which is less effective, and that women are therefore choosing the less effective option, which may lead to terminations or unplanned pregnancies.
So
Were you aware of this issue?
No, but I did phone up two pharmacies this morning. One said that it was 25 and 35 pounds, and the other said it was 20.
Okay.
Around 20.
Okay. So now that this issue has been brought to our attention, Minister, would you commit to discussing with the Minister for Social Security how you might tackle that issue with the Health Insurance Fund? Thank you.
Presumably, I think that if you had a free GP appointment, then it would be free up until the age of 23, 21 if you're a student, or 18 if you were under 18. So at the moment there are some categories who do receive it free.
Okay. Are you aware that this medication is going to be made free of charge in England later this year?
Yes, I am aware.
Okay.
But unfortunately, we cannot promise everything to everybody. We are under constraints.
Okay. Philip's gone. Do you want to do these ones?
If we move on to
Thank you.
to IVF, and we've heard in the past, or we know that you've resisted broadening the criteria for IVF, and therefore there are some groups who are not able to access IVF at the moment.
I don't think we've resisted anything at this stage. We're only in our fourth month of operation. I think what we're doing is we're monitoring how everything goes, and I think we're quite happy to revise the criteria going forward. But we need to analyse everything that's taking place and take a look at how to deal with it. So there's no reluctance on that part to change criteria. As I say, there was an awful lot of work went into this in a very short space of time, and I think so far, I don't know what your thoughts are, that it's working 16 weeks in reasonably well. There have been some qualities identified, and we're quite happy to look at those and look to address whatever emerges from the situation. It's relative infancy, I think we agree, so we're happy to keep an open mind on what we do going forward.
And what can you explain what that process is of review that you are doing, looking at that service? I mean, how responsive are you able to be?
So perhaps or do you want to take that one?
Very happy. So we collected in ARU all of the data around the couples who are eligible and the couples who aren't eligible, and then go forward to self-funding. And we then can analyse on what criteria have they not been eligible. Then inside the funding bracket, every quarter we're referring back to the Minister again with how much of the budget we spent, and giving estimations. If you were to relieve this would result in this amount more spent, so that there is a process where you can move forward and you can have hopefully sustained funding, as opposed to ending up with no budget at the end of 6 months.
Okay. And are you able to share any indications on what kind of messages you're able to convey
so
about
at
that?
the moment we're slightly under budget spend. The biggest criteria of where couples aren't eligible is where there's already a biological child inside that couple, so they have their own child. The next group that is not eligible, and that accounts to about 60% of the groups that aren't eligible, so there's already a biological child. The next group is where there is a biological child by one or other partner outside that relationship. And then the third sector would be, the third one would be where the woman has got a higher BMI, smokes, so other criteria that actually will affect the effectiveness of the treatment. And we know if the BMI goes over 30, it severely decreases the chance of IVF working. If you smoke, it decreases. So quite rightly, there should be a BMI indication, there should be a smoking indication.
Excuse me. Are you? You said part of that process is to advise the Minister on how you might go forward. What advice are you currently giving?
Well, the advice is objective. Here's the numbers we've treated. here's the groups that aren't eligible, here's what it would cost if you make this group eligible, and here's your budget.
Do you know how much it would cost to make the first two groups eligible? How much extra? So where there's already a child inside the relationship or outside?
Yeah, so where there's already a child inside the relationship, there have been, for example, 6 couples who have self-funded since this has started. So that would then put an extra 20,000 onto your budget, which would make us overspend at the moment on our quarterly run rate.
And that's in 4 months?
That's in 4 months. If you extrapolate out, your budget's gone by the end of the summer. And like that may be something that you want to do. Like Scotland, for example, Scotland have a fixed budget, and they say that's a budget for fertility services. Once that budget's spent, there's no more fertility services that year, and it goes on to the next year. But then it's transparent and open, and everybody can have it. But then you create a waiting list. So the waiting list for IVF in Scotland is up to 2 years on the NHS.
I'm happy to hand over.
I was just going to, just on the third category, I think talked about BMI.
Yes.
Where patients are not eligible for BMI, where are they? How are they dealt with, and are they signposted elsewhere to help address that for them? Because it can be quite difficult to just be turned away.
Of course. So the first part is education. Is saying why is there either on a state-funded or from a success rate? Why does it affect it? Why is there excess hormones produced in the fat tissue that will suppress the response? So educating and then reviewing and reinforcing that message is very important. Then for anybody who between the BMI of 30 or 35, if they want to self-fund, the IVF units will usually accept them, but over 35 a lot of centres won't accept them, because then you're into an anaesthetic risk at the time of egg collection, and it creates a risk-benefit analysis over the whole thing. So we certainly don't discharge people because of their weight. I will very quickly review them, see them again, reinforce, and we need to see people working towards it. But you know, you've got 4,500 type 2 diabetics in Jersey, around weight. If you give them all GLP-1 antagonists, you would save significant money going forward, but that will cost you about 7 million, I think it is, on the current cost.
That's for the layman around the table.
That next week, sorry.
For the non-medical people in the room, that's medication to help them lose weight.
Yes.
That's weight loss jabs, for example.
Suppression of appetite, yeah.
Fine, okay, thank you.
And still on the topic of assisted fertility, we have also found on the panel that the LGBTQ plus community, parts of that community face inequitable access to funded IVF. And I know it's something you're aware of. I think it's around 6 rounds of IUI are required before they can access the IVF for a same-sex female couple, and this can cost, I think, around £4,000. This has been dubbed a gay tax, and concerns that it's biased. What comments do you have on that?
Yes, so I do accept that your comments, and it would be something that we would look at, but we have to be, there are men who would like a surrogate baby and they don't get any help. So I wish we had an infinite amount of money for that we could do everything, but but I am aware that there is an
So for same-sex female couples, obviously it's different processes. Is this something that you could commit to reflecting on and get back to the panel?
we have to.
Yeah, I think it comes down to, again, your definition. An infertile couple is a couple who can't get pregnant. By definition, same-sex couples aren't infertile. So it's the same as oncopreservation. If you've got a couple, or you've got a woman or a man who's gone through cancer treatment and they preserve their gametes through before chemotherapy, in the UK, that is a separate budget from your fertility budget. So you need to look at a different budget per se, because the WHO definition of infertility and eligibility for IVF is very clear. And that group, until they've went through that 6 cycles of donor insemination, don't meet it, which I agree, because it's an easy win, because they get pregnant usually very quickly.
Yeah, and I think given the fact that our same-sex parental rights legislation requires families to use assisted reproduction to access parental rights where it's a same-sex couple, do you agree that this cost should be looked at? Thank you. Thank you.
I think given the last comment there as well about that actually they often get pregnant quite easily, to put that in the context of the declining birth rate that the island has as well, and again taking it back to a wider government conversation. But I think IVF births sit around the 5% mark in our island. It is part of the story. Do you commit to taking that into account?
We're conscious actually of everything's been raised, and we'll be reviewing all of it. So we just need a little bit of time.
Yeah. Thank you.
Do you think we should move on to this? Yeah. Okay, thank you. We're going to move on to miscarriage support. What immediate and long-term support services are available to women in Jersey who experience a miscarriage?
Shall we ask, is it right if we ask Ros Willenbell, who's in charge?
Yes, please do.
Actually, I can answer this. So we have recently we've got a new substantive consultant who is now going to be the clinical lead for the early pregnancy assessment unit. We have done a large piece of training on early pregnancy, on scanning. We now have a scan machine down in ED, so we can have early access to scans if needed. In the emergency department, but we now run a daily early pregnancy assessment unit clinic. We've got an amazing counsellor who will see women after their loss, based up at Edith Kenno. We are doing a big strategy on the Think Ectopic as well, which has sort of come from the UK, but we're doing a lot of training related to that.
Thank you. Can I pick up on the counselling that you mentioned? Is that offered routinely, automatically?
It's offered automatically, yeah.
Okay, and how many women take up that offer?
Ros will know that.
Probably at least 50%.
Okay. So around 50% of women take up that offer. And how is the effectiveness of that counselling measured?
I would say that's through audits, because some of them will require maybe one session, some will require more. So it's again exactly how many sessions they require.
Okay.
Within that time, we make sure that we review that regularly, and it's always reviewed on a regular basis.
Okay, so it's reviewed on a regular basis. Okay, I've been asked by officers to a note about mics, that if somebody from your team behind it needs to answer a question, Minister, if they could swap in and out, and also for us all to remember to speak into the microphones. Thank you, welcome.
Right.
Would you like to introduce yourself?
I'll take that one, because I know that's me. So I'm Rosalind Bullenbell. I'm the Director of Midwifery and Nursing for Women and Children. Oh, sorry, I forgot to put that on.
Yeah, go on, do it one more time.
Do it again. Rosalind Bullenbell, Director of Midwifery and Nursing for Women and Children.
Thank you.
Thank you. And can I just pick up on the ectopic pregnancy? You talked about training and strategy. Has that been led by something happening locally? I mean, there were a few high-profile cases that ended up on social media, for example, over here. Is it as a result of concerns being raised, or is it just something that needed to be done following the UK's lead?
So one of the things I've done coming into my job is focus on the governance around the gynaecology unit and obstetrics, but particularly gynaecology. We now have weekly risk meetings for gynaecology. We have a very transparent DATEC system, which is when we report any incidents, and we have had 2 serious incidents that related to ectopic pregnancies that have been fully investigated and the learning shared. The part of the thing is getting the learning shared, which has been really difficult, but now we have the weekly meetings where we share the learning. We've trying to make it a no-blame culture, so we're really trying to break down the kind of barriers of learning, but yes, there have been two incidents that we've looked at.
Thank you.
Okay, thank you. Are there any plans for reviewing the clinical pathways and also the information available for women undergoing pregnancy loss?
Okay. Yeah. So I also lead on the recurrent miscarriage clinic. So 1 in 3 pregnancies will miscarry. That's just the statistics nationally on it. If you have a recurrent miscarriage, used to be diagnosed as 3 or more miscarriages, in which stage that merited referral to a tertiary centre or secondary centre for investigation. And there are some, maybe 5% of times you can find a reason for the recurrent miscarriage. Having worked with the team in St Mary's on this, that has now been brought down to 2 miscarriages. So the clinic up at Edith Kennedy, which we have, again, it's a direct referral, so either the midwife team or our colleagues down in the hospital can refer up, and we will see them immediately. We will see women after 2 miscarriages, we'll investigate them, and importantly, we'll offer them with their next positive pregnancy test, early ultrasound scanning, support, direct contact with the nursing team in ARU to support them through that next pregnancy, which is very distressful for them and when they need that support. So we have the primary care level where they have the first miscarriage, as Caroline talked about in the hospital. If they go to a second miscarriage or more, then they come up to our team at ARU and we look after them then.
So bearing in mind that sometimes those very early losses are happening at home for women and they're not even necessarily on the radar, even in primary care, can women self-refer?
Definitely.
And do you think the message is out there enough so that women know that?
We properly get that down through the primary care board. So, and if there's any other way that we can put it forward on websites, we will do it. If you've had 2 confirmed miscarriages, so not, oh, my period was a bit late, but we need to know that it was a confirmed. But even if it's not confirmed, they still have a psychological need to have a conversation, so we're very happy to see them. We don't have any waiting time. We're quite efficient in the clinic, so we can see them inside 4 weeks.
I wonder if that's something I could ask the ministers, if you could look to maybe do some communications around that, because I don't think personally that's a message I've seen, and the 2 number, I think it could be really helpful.
Actually, I until very recently, I was not aware of it either. So it is on part of our plan, is that we need to let people know what is available.
Okay, thank you. We're going to move on to questions about the home birth service.
So the home birth service was suspended, is currently suspended. How does that, and this is a political question I think really, how does that decision align with the need to emphasise women's autonomy and reproductive health?
It wasn't a decision taken for political reasons. It was a decision taken for on professional advice, and I would have to hand over to Ros to articulate what those reasons were.
So I think the decision was taken, obviously it was a proactive and precautionary measure, because when I came into post I reviewed all of the services within the maternity improvement plan, and one of them was the home birth service, and I became aware quite quickly of, it's not about the experience of a midwife being able to be at a birth. It was more about the coping with emergencies within a community setting, be that within a neonate or within the mum herself. And that then led to me to think that I absolutely have to look at the training and the resilience of the staff, and making sure that we've got a model that absolutely is appropriate to provide adequate and safe service within our home birth. So we then did very much looked at the reasons for the home birth service. We've done a massive mapping exercise on that as well, to pull out where we feel that we need to strengthen things, one of them being our guideline, our criteria, and obviously the training is the one aspect that we're sitting on at the moment that we absolutely have to get done, and obviously that training is planned for the 3rd of July, which we are doing with our paramedics as well as our midwives.
I'll come to the future in a moment, but what options and support are currently available for women who are planning or would like a home birth?
So if they, at the moment, obviously we're unable to give them a home birth because we haven't got the training and the support of it, but we have got a midwife-led unit. We have got 2 birthing rooms that are midwife-led. One of them has got our birthing pool within it. The other one has got the active birthing room, which has got birthing chairs, has got birthing cushions, has got cubes, etc. So it's a variety of things. So we very much, any woman who is asking for who actually requests a home at the moment, I am actually meeting with the majority of them myself, alongside their named midwife, so we can talk that through with them, and that they can understand the reasons behind the temporary suspension of the home birth service.
You say temporary suspension. What timetable or any kind of information can you give us about when home births might be available again?
So obviously once we've done the training, which is the beginning of July, then we will be going to our chief officer to give him all of the information, to give him that assurance that I feel that we're ready to reinstate, and then it's for him to make that decision if he's happy on that date. So I can't give you a timeline at the moment on that date, but I will be going to him in July with all of the information and giving him all the assurance of that what we've done in that time.
Is there anything that would stop the home birth service for a more long-term reason? could it be that you would recommend, no, we're not going to do home births?
No, my intention is absolutely to recommend its reinstatement. I think the one thing that I need to tell to islanders is that we are on an island, is that we have to make sure that we're looking at our activity and our acuity and our staffing at any one given time. So our priority is to try and make sure that we have got home birth service, but we will never ever be able to give it 100%, because if it was that we were busy within the unit, we have to look at our activity and acuity and staffing. My intention is to make sure that our staffing is utilised effectively and efficiently for every single woman that requires maternity care at any one given time, but we want to actually have it as a service that we're able to do. If it was that I was able to offer it 100%, we'd have to have significant investment in the number of midwives that we'd have to have on our books at any one given time. At the moment, we've got a set number for the number of births we do, but if we wanted to provide a 24-hour service for that as well, we'd have to increase the number of midwives that we had on the island.
Understood. I just want to ask about the service, the home birth service as a whole, because as I understand it, part of that home birth service was a community midwife would be able to visit a woman in her home rather than her having to go into a setting, and that continuity of care, I think, was easier to achieve with a home birth pathway. Are you able to still offer some of those elements to women who feel that they need that?
We very much now, we have a hybrid model of our maternity units, that we have some of our midwives work within 50% within the unit, 50% within the community. So therefore they are getting to meet a lot more midwives, and there'll be 2 named midwives for that one woman, so she will get to know that midwife as well. So we are trying to do that continuity of care. We're also looking at, as part of the work with the home birth service, about the continuity of care as well, and we're looking at team concepts, etc. as well, so we can strengthen that continuity of the carer within that as well, and that's given us that opportunity to be able to do that as well.
Minister, you've spoken in the past when you talked to us about the possibility of charging for the home birth service. Is that something that you still are taking forward?
No, that was in the context if the population generally wanted 100% guaranteed 24/7 service, as well as what pointed out, would cost a significant amount of money. Undoubtedly, it would also be quite difficult, because there aren't sufficient home births to have the right amount of people trained all the time. There are other complications with it that would cost a lot of money. So, given that we haven't got anything spare in the budget, I have to be guided on best practice and safety. That's what I'm guided by. So, the service will come back on when it's ready to come back on, and it'll be a sort of service that we can afford with the financial envelope that we've got.
But can you clarify, is it still your intention to propose some charging mechanism for home births?
No, it was an immediate statement. I'm not sure what services would be available if somebody wanted to pay independents to come in and provide that. That was the point I was trying to make. If somebody wants that and there's a service from elsewhere available, that would have to be the way it is. And make it plain again, as we made plain today, that the service can only be offered to the extent to which it can be afforded within the current financial envelope.
So it will be free, but it may not be as extensive as...
It's never been 24/7. As I understand it, correct me if I'm wrong, we've never had a service that was guaranteed 24/7.
No, to have that, you'd have to have an awful lot more midwives. That within the number of births we have, we've got absolute adequate midwives to be able to perform everything. But we never know within the maternity service what's going to go on at any given time. So I need to make sure that every single woman is getting appropriate care, be that in the right setting. And the first thing, sometimes, because you have to send 2 midwives out, might be that we're not able to give a home birth, but women will be aware of that. But we want to try and make sure that every midwife trains so that we can give them the best opportunity to be able to have a home birth, if that's their choice.
If the money was available, that would be great. But I think virtually everything we've discussed today could do with more money. I think you agree.
I think the issue that sometimes is made is that, abortion women have to pay for, home births they may have to pay for, at least that was being discussed, contraception paid for. There's a lot of women's issues which are lower down the list of priorities, it seems, in terms of payment.
I don't accept that, to be perfectly fair. And as I say, we are constrained by the money that we have, and if you can help in some ways as politicians to increase our budget, that's fine.
But it's a £320 million budget, and you've employed 190 people in the last year, extra people in the last year. So money is available for some things.
Well, I'll make this point again, I know we're short on time, but looking at the internet, when I was born, I think the life expectancy was just over 71 years. It's now combined with women and females, 82, 83, people are living another 10, 12 years longer, and medical science is every year coming up with more drugs, better operations, and more financial requirements to keep people well for longer. And we cannot square that circle. Our budget is rising exponentially, and that's a reflection of all of the increased costs that we have to bear. So we're in a no-win situation.
But do you accept the point that from the outside at least, it looks like women's health issues are the ones that always are the ones that go down to be paid for or be more difficult?
I don't think that's necessarily the case. And as I say, if we can make changes, we will, but we are constrained. And we face every day, the team faces very, very difficult decisions as to where they apportion money.
What evidence do you have, Minister, that that is not the case?
Well, I'll put it the other way around. How would you say that? Where's your absolute evidence that it is?
Okay, so one of the findings in the Women's Health and Wellbeing Needs Assessment was that women reported that cost is hindering their ability to maintain their health. How would you respond to that?
Well, I'd argue that we haven't got a men's health group. We haven't done any work on men's health or children's health, and it may well be the same for them. I'm not saying that there aren't issues here. I've made that plain all the way through. If we could do better than we're doing, we would. But if you feel that money should be transferred from another area of health to women's health, that's fine, but we have to go through that, and we have to justify whose operations we're going to stop, what cancer treatment we might stop. These are very, very difficult decisions. And I say I get some very, very compelling emails in my inbox from people looking for more money to keep them alive, for example, and we have to go through a process for that too. So it's not a game. Nobody's anti-women here at all, but these are just very, very difficult decisions.
Can I just say that we have reduced GP costs for everyone during our term, and we've also made period products free, and we have also, there is no charge for termination of pregnancy if you are under 18, a student, or if your pregnancy is a result of sexual assault.
Minister, I think sometimes women, but maybe those around them as well, would just like to hear an acceptance of some of the evidence that's put forward from your own government as well. But just an acceptance and acknowledgement that yes, there are challenges, and yes, there is data showing this. And I appreciate we can't solve everything, and you certainly can't solve everything yourself with a limited budget as well. But I think that's one of the things as the panel would just like to hear is an acknowledgement of those challenges that do face women, because we are in a women's health hearing, rather than just a defensive attitude. I suppose that's what we're asking for on behalf of the public.
I'll make it plain. Okay? I accept everything that's there, and I acknowledge it completely.
Thank you.
And I'm very keen, as I said at the beginning of it, to resolve as much of it as I can, as quickly as I can. I take my role very seriously in terms of, as far as I'm concerned, if I improve the overall health service, if I can politically help to improve the overall service, well, as I say, when the time comes in, all the boats rise, and I can do a lot for women's health by concentrating on making a more efficient service. That's why we've devised a partnership board, which I think is going to make things better. And as I've made plain on a number of occasions, I'll be coming to the Assembly for a lot of money to improve preventative care, and women's health issues will come into that very, very clearly, and digital connectivity. And we're talking of a sum probably in excess of 100 million over 5 years. And I want that as additional money. I don't care where it comes from, if it comes from strategic reserve or whatever. If we make the health service more efficient and more effective, that gives us more money, more efficient, more resources to women's health. Very, very happy to do that. I've said all along, I've got no issue here at all. Very keen to make it all better.
Thank you, and I appreciate the acknowledgement, and I'm sure others do as well.
Thank you. Do you want to follow up?
Could you, I mean, that was very interesting to hear you talk about the money there. Can you talk at all about how that money, that process of getting the money, accessing strategic reserve and so on, is going?
Well, it may or may, I know I'm being listened to, and I don't want to create unnecessary headlines. I'm using that
well,
as
we do.
Fine, but I don't want to make unnecessary controversy. But as an island, we've got reserves, we've got a strategic reserve, we've got problems in health, we've underinvested, we've failed to recognise the exponential rise in health costs. Health has been criticised horribly. When I first came to this, all the pressure was on health. You're overspending, you're wasting money. Yet there were elements of waste, but there's a lot of good people doing a lot of good work. And they're confronting a huge amount of very complex problems. As I say, we take our role as being in the round trying to improve all of that.
But per cap, sorry, do you want to move?
What I wanted to ask, Minister, is do you acknowledge the findings from the report that there is a disproportionate need for healthcare from women as opposed to men, and therefore perhaps a greater need for investment? And will you prioritise accordingly?
I'll acknowledge anything you, well, within reason, anything you say. I can't argue. I wouldn't argue with anything that's been presented. And as I say, there's a real commitment from everybody. There's some really good people working very hard to try and deliver that.
So we can expect to see the findings from this report reflected in your policy making going forward?
To the greatest extent possible, yes.
Great, thank you.
Do you want to touch on capital and the bigger picture stuff?
Well, I was going to say that per capita rather than capital, per capita our health spending is roughly similar to the UK's. And do you feel that we need more than, say, what the UK is spending per capita?
If I'm perfectly honest, it depends whether we want a better health service or not. I would argue, and perhaps there's some professionals here that might bear me out, I think our health service is as good as anywhere in the UK. I know there are points of excellence in the UK with specialist centres and so on, but I would say generally, I would just as happy to be treated in Jersey as anywhere else, and probably more so. So I think we start from a pretty good base. But I think in an island where we're trying to attract people to come and work and to live and to come on holiday and to invest money, we've got to do more to tick every box and make sure we're right. One of those things is a new hospital that should be there in 4.5 years' time, and it's our absolute intention to try and make sure we've got a first-class health service to put into a first-class hospital. And I think it'll take all of 4.5 to 5 years to achieve that.
Thank you. We're going to move on now to the termination of pregnancy law amendments, which I know you are working on, Minister. Can you briefly describe how this amendment will address any barriers to accessing these services, particularly related to stigma and reliance on GP referrals, two things that were highlighted in this report?
I think we're hoping with the new termination of pregnancy law that women will be able to self-refer into the termination clinic.
Okay. And in terms of stigma, how is your work tackling the stigma associated with accessing terminations?
There's no necessity. Well, if it comes about, you will only have to have the agreement of one doctor.
Okay, thank you. In terms of the cost of accessing a termination in Jersey, there is a significant difference in the fees for Jersey residents, £185 versus non-residents, £511. How will you ensure that cost isn't a barrier to low-income or any vulnerable non-resident women, such as migrant workers or carers, Assistant Minister?
Well, it is another difficult question.
Could I ask Ruth, who's been working on the policy drafting, who can give you a fully comprehensive
Can I just ask for the Assistant Minister's reaction to whether she feels those costs are appropriate?
I have written a ministerial decision, so if you're under 18, if you're a student under 21, or if your termination is necessary as a result of sexual assault, there is no cost involved. But unfortunately, it's a very hard call.
Why is the cost so much higher for non-residents, Minister?
I think it's to do with the social security, paying into the social security.
So the costs associated with termination of pregnancy are historic. I can't start to work out or explain why they are what they are. What we're doing as part of the amended law is we are introducing a order-making power. So the termination of pregnancy fees are developed by order, which therefore requires a degree of vigour. And it also means that in developing those fees, the Minister must accord with the Public Finances Manual, and there can't be any degree of overcharge or additional charge within it. So we will certainly be looking at those fees and the variation of those fees as we move forward.
Okay, thank you. What steps are being taken to ensure that both clinical and administrative staff are trained to deliver care in line with best practice and gender-sensitive, trauma-informed principles when women are accessing terminations?
I think it's technical, but we would have thought that any treatment that any person receives in our healthcare system is kind, compassionate, safe,
Is there a trauma-informed approach to care in this area? Can any of the...
If you look at the UK, and the vast majority, so where I came from in Oxford, vast majority of termination services aren't carried out by the principal hospital, they're outsourced to BPAS. And that comes from the fact that when you're employing juniors or senior or colleagues, you cannot ask directly, will you carry out a termination of pregnancy? And they have the right then to object on a
Conscience.
yes, that they don't do it. So extremely difficult and challenging for any service, especially here where you're on an island, to actually maintain that service. And it then does depend upon a number of individuals, which that there's an onus on. But that also affords an opportunity in that it's the same people doing it all the time. So you've got actually a lower cohort to actually train and ensure that they're given that service.
Minister, would you seek to investigate whether services in this area are trauma-informed and get back to us? Thank you.
Can I just move on to menopause support? We're aware that the Listening Lounge has been offering 6 weekly sessions for women to discuss their experiences with menopause. Can you give any feedback about how those are going?
So the Listening Lounge, I'm not aware of. I know I lead the secondary level menopause clinic in Jersey, and again, about 20% of women won't respond to HRT. Just through physiology, they don't respond, but there are other options, and that is what we would tend to see in the menopause clinic. Again, no waiting time for that. It's 4 weeks maximum, and they can be seen. So the psychological and physical changes that happen in the menopause are quite profound. So there's no doubt that women experience significant distress in that menopause, especially even around mental health issues. If there's underlying mental health issues, those are exacerbated at the menopause because of just a change in the neurophysiology that happens. So we do need to have a support mechanism. Our primary care colleagues look after it extremely well, and then we have a tertiary level that is available. The specific feedback from Listening Lounge, I'm not aware of.
We could try to find out.
Well, I think to move it on, I mean, are there plans to set up any Jersey-led support, any Jersey support services, specific Jersey support services, similar to the UK initiatives such as Menopause Matters or the British Menopause Society?
British Menopause Society I've been a member of, and I know them extremely well, so I know all of that. And getting part of it is actually, again, informing, getting information down to patients. And one thing the Minister mentioned earlier was about digitalisation onto it. So through the NHS app in the UK, we can push information to selected individuals, so you can actually, hey, read about the menopause, here's something about it. So getting that across to women, understanding what support there is, because it is complex. It's not just the hot flushes or the mood swings, but there are numerous other physiological changes.
I guess what I'm trying to get at is, are you comfortable with what we've got, or do you think more needs to be done?
We should never be comfortable with what you have. There's always room for improvement. We always need to improve in the service. We always need to improve communication, and we always need to update the information that's there.
Is it true that there is no menopause specialist in the gynaecology?
Sorry,
sorry.
I'm so specially trained in the menopause. I am sorry.
So not true then?
That's not true.
Yes.
And
there's no doubt about
in
that.
terms of your expertise,
Yes.
then how do women access that?
Again, that is a 4-week waiting time onto it. It can be referred through primary care or through my colleagues who have got failure to treat effectively in secondary care. I'm very happy to see them again immediately.
Okay. Can women self-refer?
They can self-refer, but they should go through that, because I'm a limited resource as such, so you want to make sure that actually have you tried HRT, have you tried the standard approach. It's only when you get treatment failure that they should come to that level.
Okay.
So there are very clear guidelines through the British Menopause Society, very clear pathways that we have actually pushed out to primary care.
Thank you. And just to reflect on, so some of the submissions we had were of the view that there wasn't enough specialist care. So if there is
4-week waiting time.
specialist care,
4-week waiting time.
How could we ensure that this information is being disseminated to women so they know it's there?
I think it's a communication thing as well, but we have got some very good champions in the community who have really raised the profile. Who've been doing great work, and they've brought over specialists over here, and we've also got the GPs are doing, lots of
Very
them
good.
are doing extra training in menopause, and there's a menopause support network for all government staff. And I'm hopefully that the stigma around menopause is being, the taboo is being broken, because it's really serious. But I think in the workplace you can now ask, if you can be in a place, you can express that you're going through the menopause.
Yes.
If you can't talk about it, there's a special form that you can fill in, and you can ask for, cooler place, different clothing, a time off, if you know.
Thank you. And all of this information, where is that available for women to access?
That is part of what I've discussed, because it's not out there. It's not widely known, because every woman is going to go through the menopause at some stage, and some people just sail through it, and other people have a really rough time, and then in between got all sorts. But it's also a case about living well, and probably that Daniela could say, but eating the right things, exercising, getting off the bus, running, walking the last bit, taking the stairs.
Thank you. And in terms of the work that you're doing to improve the communication around this, what's your timescale for achieving that?
I'm so sorry, I cannot say how, but it is something I'm so sorry.
Will it be completed by the end of this political term?
Yes.
Okay, thank
And
you.
now a very important part of that is actually premature menopause, which is even much more complicated and needs to be. It's got fertility issues around it, it's got perception, and that can be at the age of 15, 16. Some of the girls that I'm seeing are through menopause at that age, and they've got their whole life in front of them. But again, we have a specialised clinic for that.
Thank you.
Communications.
Microphone.
It's an ongoing issue that really needs improvement consistently, and I'm very much hoping that the digitisation process is, once you get everybody walking around with their medical records on their phone, that you can actually message people with all of their health requirements and all the options available. A full digitised system over the 5 years is going to make a big difference in communication.
Sounds good. Thank you.
I wonder if I could just very quickly ask the Minister, perhaps slightly uncomfortable considering that Enda is sat in front of me, but we've heard today that a lot of things are falling to one consultant in the area of women's health, and it's great to have that expert knowledge, but what resilience is in place to ensure that should that consultant have other personal plans which he's fully entitled to, or he decides to take a holiday, given that, he might need a break, what resilience is around that system so we're not just relying on one person?
So I can just take part of this, is that we have had reliance on locum consultants. We've now substantiated, so we now have a full workforce of consultants, and we are increasing our, it's called their staff grade and associate specialist doctors, which is the sort of, I'm not going to say junior doctors because we don't call them that anymore, but those that aren't consultants. So we're expanding their numbers as well to give them specialist treatment, so specialist training, so that they can then be empowered to take over Enda's clinic when he's not here and things like that. So we're doing a massive piece of work. So we've got 3 new consultants that we interviewed last week, and they've all taken the role. They'll start in about July. So all of those. So we've got certain areas that they will have as expertise. So we've got a sort of gynae consultant who's going to take on a lot of the women's health. We've already got a new gynae oncology lead who's also leading on the early pregnancy assessment unit. We've got a urogynae specialist, which is an area that's really difficult to recruit to. Got an amazing guy starting, and then we've got a lead for our labour ward who'll be taking on fetal medicine and maternal medicine. So it's something that I've really care about, and then also employing specialist nurses and other people who can take on a lot of these roles. But you're right. The one thing I picked up today is that dissemination of information.
Thank you.
Thank you. And again, it's really positive to hear of those developments.
Safe to say, and I think you've beaten me out, we start from quite a long way back from having had a lot of locums in place. And we talk about resilience, but the first thing you need is permanent consultants. And a lot of progress being made in a lot of areas on recruitment. So well done to the team. They've really made a huge effort. You can then build in the further resilience once you've got the permanent people in place.
Great, thank you very much. To move on to the maternity unit improvement plan, As of January, I think last year, we had 87 out of the 127 recommendations from the improvement plan had been completed. Can you provide an update on where we're at currently with how many have been completed and any other significant milestones to do with that, please?
Can I just do a time check as well? We have got 2 more sections to get through in only 10 minutes, so
I'll be as quick as I can.
speed up once more.
So I think the maternity improvement panel obviously was 127 recommendations. Of them now, we've actually only got 1 of those that are not business as usual, and I'll go into it in a minute. Obviously, every single one of the other 126 have gone through the 30, 60, 90, 120-day reviews to make sure that they're business as usual. And now that's our baseline of where we actually make sure that we audit that as regularly as possible to make sure that that is how we are approving. The one that is not closed yet is the culture, and I think that that is because it's a big issue. It's not something that will can be resolved overnight, so it's something that we've not closed yet because we want to make sure that we have introduced our timed chats. We have weekly MDT meetings, which are very much MDT approach. We've all had psychological safety in the workplace training, and we've done that as an MDT approach as well. We've obviously improved the communication across the unit threefold, and we have daily safety huddles at 3 points throughout the day. So I think we are still on that journey with the culture, so we don't want to change that. I think one of the biggest things we've got, obviously with our new consultants happening, but we've now got no agency midwives within our workforce either, because we've been able to make either some of them substantive, or we've had other midwives who come from the main from the United Kingdom to work with us as well, and they have taken up substantive roles. So that is something that we're very proud of now, not to have any agency. So I think that now we've got a very strong workforce that is permanent, is one of the real things that will help us to be able to close that cultural thing, but we absolutely don't want to close it until we know that we've gone through everything possible on that journey for culture.
Thank you. And have there been any measurable changes in rates of interventions, for example, since the improvement plan was introduced? And if you've got any feedback about how the refurbishment of the unit has also helped patient experience as well?
So I think that we've, obviously patients' experience is something that we do take, and we do ask our anybody who uses our facilities what they use. We have had an awful lot of feedback in relation to the birthing pools that we've now got that are permanent. We've also got a room that they can use for an early labour or for their induction of labour. So we absolutely, have made some really great changes. We've got tours of the unit now as well, so that women can actually come and look round. We work very closely with Baby Steps, which is who provides all of our women with their antenatal education, and they now do a tour within the unit as one of their labour talks, so actually making it very interactive. So when they do come into the unit, they're actually seeing what our rooms look like and actually what the environment looks like. So I think there has been an awful lot of positive feedback on the refurbishment. We have also uploaded the new tour of the unit as well onto our website as well, and we are very much looking at the whole of the maternity website and information, and that has all been updated from the physio stuff that we do in relation to any of the counselling or anything that we're able to offer them, or debrief service. That has all been updated at the moment.
Yeah. And as far as interventions go, is there any data to show any changes there?
So we have looked, obviously the data we have, one of the biggest ones would be our blood loss is after when they've had babies. We had a very, very big proactive check last year, and the number of massive obstetric hemorrhages was quite excessive in 2023. We then looked at that, and we've made a massive 50% decrease within that, and that's been an awful lot of education, an awful lot of learning, an awful lot of stuff that we've had our practice development involved in, our risk midwife involved in, and that is something that we're very proud of, and we've done that audit, and that audit goes every day, that anybody who does have any blood loss, we review it on a regular basis so that we can make sure there's any learning, we embed that in practice.
Can I just clarify? So you mentioned that 126 of the recommendations are business as usual. Does that mean they have been achieved?
Yes, that means they've been achieved, and they've been through the cycle of the 30, 60, 90, 120 days. So they've had that 4-month review as well to make sure that they've been embedded as business as usual as well.
That's something to really be celebrated, isn't it? So thank you for sharing that with us.
No worries.
In terms of breastfeeding, the Births and Breastfeeding report states that around only 23% of mothers aged women 24 and under were still breastfeeding at 6 to 8 weeks. Is any work underway to establish what differing needs different groups of women might need in terms of breastfeeding support?
So we're very lucky we've got an infant feeding support midwife in place, which we're very proud of. They work very collaboratively alongside our, obviously, family nurse partnership as well. They have achieved level 2 BFI within the hospital and level 3 within the community recently as well. So there's an awful lot of work that we're doing, and we do regular monthly audits on that as well to make sure that all of our staff are educated. Our infant feeding specialist runs a 2-day workshop, but that all staff, as soon as they join the organisation, they undertake that, so that we're given a consistent message about feeding so that we get people off to the best start.
Thank you. And very briefly, could you outline what might be needed in terms of breastfeeding support to reach that optimal level?
So I think that is just about having breastfeeding champions, and I'd say that that is something we're very much working on as well. We have got an MSW now that is a breastfeeding and works very much alongside our infant feeding midwife, and I think that we're just strengthening those, and actually we're also about making, like our infant feeding specialist is also doing additional training, become a lactations consultant, and I think that will be really strengthen our knowledge and skills within our workforce.
Okay, thank you very much. We have some miscellaneous questions now about health conditions affecting women. I'd like to ask about osteoporosis. Women have a much higher risk of developing osteoporosis, are 3 times more likely to break a bone before being diagnosed with osteoporosis. Can you, Minister, provide an update on the status of the waiting list for a DEXA bone density scan, which in July 2024 stood at 400 patients on that waiting list?
I might not surprise you, but I can't.
No.
I'm not sure we've got anybody here for that.
We may have to come back to you from the...
Happy to, do that.
Okay, yes, if you...
I mean,
if you
I
could
know
come back
how
to us.
important it is, though. And sometimes if you're, if you have HRT for your menopause, then you're perhaps protected better, but it's also you need to exercise and eat all the right things so that you're...
Thank you. I think we'll probably follow that one up at the next hearing.
I hope all your miscellaneous questions aren't as difficult as
This
that
is a
one.
quick
'Cause
fire round now. Postnatal physiotherapy, I think we discussed this in a previous hearing. Can you advise if there is routine postnatal physiotherapy support? Sorry.
So this is an area that we've really strengthened recently, and we're working very much with our physiotherapy team, and they're going to have on their website as well, they'll have all the information so that women can access it immediately and how they can access that service. So yes, it's definitely something we have strengthened.
Thank you. And will our service be comparable to countries like France, where women are offered a number of sessions? Every woman is offered that routinely.
Any woman who would like to have that, and I'd say that that's some of our work with our new consultants as well, that we're taking on board, and I think that they will be working alongside, so it'll be very much an NDT approach as well.
Okay, thank you. And Minister, will you ensure as well that this information about these new services is widely made available to women?
Yeah, I am aware that it's a real...
Thank you. Another miscellaneous area. So we've become aware of a study that found that autoimmune diseases affect 13% of women versus 7% of men. So indicating women are twice as likely to be diagnosed with an autoimmune condition. There's currently no published data that we could find on the prevalence for autoimmune diseases disaggregated by gender in data, unless that your public health colleague. No. Minister, would you commit to investigating?
Yeah, very happy to commit to investigating.
Yeah. Thank you. We look forward to hearing. Do you have anything miscellaneous? No. Okay. Okay. Thank you. So, just to end the hearing, I wanted to thank the ministers and the ministerial team. It's been really interesting hearing about some of the recent improvements, and I think there have been lots of positive developments that you've shared with us today around the breast screening, around the maternity improvements, and certainly the increase in staff in the obstetrics and gynecology department that I think women in Jersey will be heartened to hear of the attention that's being paid to those issues. issues. I was also heartened to hear, Minister, that you accept the findings of the report, and there are several areas that you have committed to coming back to the panel, so we look forward to hearing more information on those areas. And for members of the public who are interested in following developments in the women's health sphere, we will be writing to the Minister to prompt some of those updates. You'll be able to view those letters. They'll be made public on the Scrutiny website, so if you just Google Scrutiny Jersey Health Panel, you'll be able to find our page and see all of the correspondence in this area. As I said at the beginning, please do fill in your feedback cards and let us know whether you found this to be beneficial today and any other improvements that you would like to see, either in the way Scrutiny operates or any areas of women's health or any areas of health or social security that you'd like the panel to look into. And as the Minister said, we're also always available on our emails to receive any feedback from the public. I'm going to ask if my panel want to add anything final before we wrap up.
I would just reiterate the point about being open to hear from members of the public. We take a lot of leads from the public. When people get in touch with us, it's very, very helpful to hear from the public. And we enjoy that part of our work.
I do.
And I suppose I'd then just add that I think, as we've heard today, a lot of the discussions have come from things that have been raised by members of the public, either putting experiences on social media that have prompted questions or action by the department, emails to the Minister, emails to Scrutiny. I think we all, as a community, have a part to play in the discussions around women's health, breaking down some of the stigmas we've talked about. It's not just about the department putting the information online, it's about all of us talking about it, as well as many people in the audience know. So thank you for all that many of you have done as well, and let's keep talking about it.
Minister, would you like to add anything before we close the hearing?
Yeah, I don't want to keep people, but in the first instance, I'd like to thank you. This is all rather daunting because it's a much bigger audience than usual, but thank you for doing that because it's given us a chance to hopefully display where we're going. I'd like to thank the people that have taken the time to turn up today. I realise that we're far from perfect. There's a long way to go. I think it's going to take 5 years up till the opening of the new hospital till we get things really, really humming. But what I hope you've seen today is there's a team of really, really good people working exceptionally hard to make things better. And people that are taking women's health extremely seriously. So if you take nothing else away from this, at least you know that there are some very, very professional, very hard-working people working on your behalf. So, and thank the team as well. Thank you.
And we as the ministerial team are also very welcome. Do get in touch with us if you feel that we can do anything.
I forgot a special thank you.
Thank you, and I'll close the hearing on with a message for the women of Jersey that please continue speaking up, please continue supporting each other and advocating for your health needs and for each other's health needs, and to expect the highest quality health outcomes and health services, keep talking to us. And thank you everybody for attending today. I'll close the hearing now. Thank you.